This is my first time in Hungary, in Szeged. It's beautiful, and the hospitality so far, and Andrea took us to parts of Budapest yesterday, and I saw that the Danube is really blue, and I always heard about blue Danube, but it's really blue. It's not green like the rivers in the US. And Peter said that I think Iowa City and Szeged is similar, and I just have a slide about this. So I'm from the central United States, so Midwest, and I think there are a lot of similarities. I don't know if this shows. So Iowa City is just right here, pretty much the middle of the country. While Hungary, I think, is, in a way, in the Central Europe. We don't have any access to oceans or seas like you do, but we have a river, and this is Iowa City, this is Szeged. Of course, we don't have this beautiful building here, but so I'm on this side of the river with the hospital. On the other side, it's anything other than the medical school. It's wonderful, and it's an honor to be here. So my son already gave you an introduction about acute pancreatitis. And it used to be an uncommon disease in pediatrics, but now we see more and more. And I agree that there is an increased recognition about pancreatitis in children because we suspect more, we order amylase and lipase more often than we do. And a lot of times the kids with acute pancreatitis, I think relative to the adult counterparts, do okay. I mean, they don't have very severe disease. It's only one single episode, and they recover quite well. But there is a subset that starts with acute pancreatitis, and the incidence we're finding, it's very similar to adults, probably about 1 in 10,000 that recur. So it's an acute recurrent pancreatitis. And 15 to 35% of them become recurrent. I think it's probably closer to the 15% than the 35% as the trigger continues. So we have an inflamed pancreas that later develop into chronic pancreatitis. And what is the incidence and epidemiology of chronic pancreatitis in pediatrics is largely unknown. There are studies from Netherlands and from Mayo Clinic that looked in younger population, less than 34 years of age, and that was about 0.5 in 100,000. But we don't have the exact incidence for chronic pancreatitis, at least in the US. And the etiologies, my son showed this similar slide to this, is not the same for AP or versus ARP and CP. So a lot of times the kids have a systemic disease, Henoch-Schönlein purpura, HUS, and then the pancreas is involved. There are some trauma cases, there are biliary cases, there are a lot of idiopathic cases, but in general the genetic diseases in just one single episode is not very common. When we look into the genetic risk factors in kids with acute recurrent pancreatitis and chronic pancreatitis, we see a whole variety, and there are centers here from Korea, from Poland, from Germany, and the incidence of risk factors for genetic risk factors in ARP and CP, if you look at the literature, it's quite a range. It's anywhere from 5 to 80%. But some cohorts are quite small, mainly single center studies, and not always all the genes are tested. So in summary, our knowledge about pediatric pancreatitis, and especially I think when it comes to acute recurrent and chronic pancreatitis, is limited. We do not have evidence-based guidelines about how to treat, how to diagnose, what are the prognostic factors, and in general, we don't understand the epidemiology and the etiologies and the risk factors and what happens with those kids over time. And because we don't have established guidelines in pediatrics, a lot of times we rely, as my son said, on adult guidelines. So we look to our adult colleagues about how to treat those kids with acute recurrent and chronic pancreatitis. And but is that really the correct thing to do? Because in pediatrics, we do not expect to see alcohol and smoking in high percentages. And then because pediatric acute recurrent pancreatitis and chronic pancreatitis are uncommon, we need multi-center studies. Just looking at the retrospective studies and single-center studies may not be enough. And that's how the idea about INSPIRE came about. And actually, my talk about INSPIRE goes from INSPIRE to acute recurrent and chronic pancreatitis. So I attended the Pancreas Fest meeting as Dr. Whitcomb, he's here, he was the organizing. And my goal was at that time, I was working on the CF pig model, and I just wanted to see what's going on in the pediatric pancreatology in the US, and I attended this meeting. It was a wonderful meeting, but there was nothing about pediatrics. The last day I was excited because I was going to meet the other pediatric gastroenterologist, which is Mark Lowe, and he was going to give an update about pediatric pancreatology studies in the US. And then he got up and said, well, it's easy. There's nothing because we don't have any updates. There's nothing going on. So it really INSPIRE started with just two of us talking and said, well, we need to do something about it. And we identified the names of people that we would like to contact and see if they would be interested in joining a multi-center study. So the name actually was not INSPIRE first, and I think in order to understand what was going on in my mind, you have to know this Iowa facts. I mean, I was a big pork producer. I think probably we're the top in the nation about pork production. So I'm going to ask you, what is the number of pigs raised in Iowa at any given time? Any guesses? Maybe. No idea? I do not even a guess?
10 million.
10 million says, and it's not correct.
1 million.
Not correct.
100 million.
That's too much, Peter. You've been to Iowa, but so it's actually 20 million. And so what is Iowa's population?
5.
It's not 5. Someone said 3, so 3 is pretty good. So 3.1 million. So I live in a state that, outnumbers, pigs outnumber humans 1 to 7. And then I work on the CF pig model. So what is going in my mind? And, of course, I'm thinking about pig. And our name actually was, we were pigs first. So we were pancreatitis interest group. So I sent, just to a few people in September 2009 an email and inviting them to the study. I think I'm just, I made it look so appealing that I think maybe that's the reason people were interested. And I said, would you be interested in a study similar to NAPS2? We don't understand pediatric pancreatitis very well. We're trying to put a registry together and a database, and we're going to apply to the NIH funding. I mentioned U34 and U01 that has huge budgets, and I think I was in a dream state at that point. And says, if you're interested, please come to the NASPGHAN meeting. So it's signed by myself and Mark Lowe, and so everybody said yes. So I think I wrote this email really well. So we were, a group of people, and we were pig group for a while, and we had this number of people who were interested. And but there were people who were not quite happy with the pig name. Not me, but I know Steve Friedman, came to me and said, "Can you change this name? It's not very appealing." I think NIH was also were a bit iffy. So they said, it's a stigmatizing name for a stigmatized disease, so you need to come up with a better name. And so that's how INSPIRE came about, because I wanted to emphasize that we're an international group. We're working on pediatric pancreatitis. We want to find answers about treatment, and also want it to be something inspiring, upbeat. I'm looking like apple and pineapple. So I guess at that day I was thinking about being inspirational. So that's how INSPIRE came about. So a year later, we called ourselves INSPIRE. And the reason we felt like we wanted to put the patients together, the groups together, and we wanted to have the children well phenotype and address the knowledge gap. And also, we wanted to have centers to work together and to do collaborations and prospective trials. So that was our goal. And we met at every single opportunity. I mean, we had all those ideas, but we didn't have any funding to go with. So any meeting that we attended, DDW, NASPGHAN, Pancreas Fest, we just sat down and just, tried to come up with ideas. And this meeting actually is quite memorable because it was in the middle of a winter storm in Chicago, being in December. And people came to this town in Rosemont, actually, in Chicago O'Hare area. So we flew or we drove, and a lot of us had trouble going back. But it was a good meeting for us to strategize about the funding. And these are the current centers right now. We have 12 centers in the US. Cincinnati Children's and LA Children's just joined us. The coordinating center is in Iowa. We have 2 Canadian centers, one Israel and one Australia. And the geography, just based upon the interests of the PIs. The PIs were enrolled first and then the centers. So we just set a lot of goals to ourselves. And I think one main thing to start with, we wanted to have the definition that were pediatric focused. There weren't any standardized criteria about AP, ARP, and CP in children. And we wanted to call the recurrent acute pancreatitis, we changed the letters a little bit to acute recurrent because there's another disease in pediatric that, recurrent abdominal pain. So we didn't want that to be confused with recurrent abdominal pain. And we wanted to survey the members. We want to be a multi-center study, but do we have enough patients? And then what do we do? How we treat the patients? How is acute pancreatitis patients are treated? What kind of tests we order? So we wanted to survey the members about what is really going on. And then we wanted them to answer the question, what do you think is the most important question in pediatric pancreatology that we should be focusing on? And then we took the questionnaires from Whitcomb's group in NAPS2, and then we adapted to the pediatric questionnaires. And this is an ongoing thing. I think every 2 years we update the questionnaires to make sure that we fit our needs. So these efforts came as a publication in JPGN in 2012. And the definitions of, inspired definitions of acute recurrent pancreatitis and chronic pancreatitis that I will present to you. The ARP is that at least 2 episodes of acute pancreatitis with complete resolution of pain and more than 1 month pain-free interval between the episodes. So that's how we define acute recurrent pancreatitis. The chronic pancreatitis, we defined one of the 3. You have to have at least one of the 3, which is abdominal pain consistent with pancreatic origin and pancreatic imaging findings suggestive of chronic pancreatitis, or exocrine pancreatic insufficiency and imaging findings, or diabetes and the imaging findings. So the imaging findings are listed here, and so that's ductal irregularities, stone structural dilation, and parenchymal changes, calcifications. And this is our survey data just to show that we thought we had enough patients to start the INSPIRE registry. So this x-axis is the number of children with either ARP or CP, and the y-axis is the people who responded. So the members thought that there was a fair number of ARP that they were following. We had some high volume centers, we had some low volume centers, but a lot of our centers, we're seeing somewhere around 10 to 40 patients in their practice. For chronic pancreatitis, the numbers were smaller. And we also asked them, what do you do? What kind of tests you order for acute pancreatitis, acute recurrent pancreatitis, or chronic pancreatitis? And I think for ARP and CP, the workup was quite similar, but we were glad to see that people were not ordering like ERCPs and MRCPs and sweat chloride or genetics for acute pancreatitis. It was mainly ultrasound and some biochemistries. For acute recurrent pancreatitis, we also were glad to see that there weren't a lot of kids who were getting CTs or ERCPs that would involve quite a significant amount of radiation, but I mean, a fair number of MRCPs, and again, some basic chemistries and genetics. I think a lot of us were ordering genetics for those patients. And this is what we define as our main goals, that this is what we will concentrate. What happens to those kids? I mean, do all the acute recurrent pancreatitis go on to have chronic pancreatitis? What is the natural history? And what kind of algorithms we can develop for diagnosing, evaluating, and managing patients with these problems, and then establish and validate diagnostic criteria. So our efforts about how we design and how we implemented INSPIRE just came as a publication in JPGN. So this is the administrative structure. So we have an executive committee and a steering committee. I'm the principal investigator, so I consult with them about how to run the INSPIRE study, and we have other subcommittees that are available. And this is our timeline, and it involves about 5 years. So it starts here with the pig name in July of 2009. About a year later, the INSPIRE name. We applied for funding in October 2011. In July of 2012, we got funded. Our IRB at the University of Iowa were approved just right before that, and we disseminated to all centers. So they started their IRB application, and everybody were IRB approved in less than 6 months. First patient enrolled in Iowa in September 2012. And then we did a lot of structural things, I mean, monthly conference calls and monthly newsletter. And we started the REDCap. We go live in January of 2013. And as soon as the IRBs were approved at all centers, we said, you know, go ahead and start the enrollment. We couldn't see as the coordinating center what those patients were, but the enrollment started. It took us a while for the subcontracting. I think over 6 months. It's just a lot of paperwork that involves NIH and our center. And this was finally done in February 2013. But because the sites already started to enroll before the subcontracting, in about 6 months, we reached almost a 200 number. And this is in May 2014 that our paper was accepted. So a brief findings about our study. So this is about, this has been going on for about 2 years for now. And I have about 239 patients with ARP or CP that I can report to you. Our enrollment criteria is the presence of ARP or CP, less than 19 years of age at the time of enrollment. And we collect clinical data, demographics, the hospitalizations and emergency room visits, what's been done for diagnostic workup, what risk factors the patients have, what are the treatments, and outcome information. And those entries are entered into a REDCap database at the University of Iowa and analyzed. So this is the breakdown of our patient. We were actually surprised to find quite a bit of kids with chronic pancreatitis, and the average age about at the time of diagnosis was about 10. So I think that's a significant problem in pediatrics. The gender, ethnicity, and race distribution, almost equal distribution of gender, but there's slight preponderance for females. And most of our patients were non-Hispanic, and most of them were Caucasian. Looking at the risk factors, I have ARP and CP here separately. The genetic factors were on the top of the list. And I have to tell you that the INSPIRE doesn't pay for the genetic testing. So we don't have the genetic testing on each and every patient. This is deemed as ordered by the principal investigator, and not all the genes were tested. So, but still, the genetics make the top of the list, more on the CP than the ARP category. The obstructive about 1/3 of the patients. Again, there could be coexisting, and that's about the same for chronic pancreatitis. Toxic metabolic was the third. Autoimmune, about 8 to 11%, and toxic metabolic and autoimmune patients is the group that we would like to concentrate on, make sure that we're phenotyping them appropriately. And the idiopathic or unknown, much higher in the ARP category than the CP category, but again, this could be moving into the genetic category once we do all the genetic testing on every patient. Here, the breakdown of the genes and also the age of diagnosis for ARP, about 8.5. For CP is about 10. So the kids are younger in this category than this one, but still quite young to get a chronic disease. And we have more PRSS1 in the CP category and more CFTR in the ARP category. And a lot of kids have multiple mutations. 6 kids had multiple mutations, the ARP, and 12 in the CP category. The obstructive risk factors, again, pancreas divisum was the most common one here. We saw more gallstones in the ARP than we saw in the CP category. And 25% of the patients with pancreas divisum had at least one genetic mutation. Toxic metabolic, here, I think the most important take-home lesson is that there's not much active smoking and there's not much alcohol use as one would expect in pediatrics. The passive smoking, I mean, it's very difficult to quantify this. I think there are some kids who are exposed to passive smoking much more than others. This is something that we're trying to develop the guidelines about the diagnostic features of this. And the hypertriglyceridemia, it's also relatively small. The medications, again, makes a big category here, also something we're looking into closely. So in summary, the genetic and the obstructive factors are the main risk factors in ARP and CP, and toxic metabolic factors were uncommon. How we suspected chronic pancreatitis in children, a lot of times because there were multiple attacks. I mean, the kids presented with acute recurrent attacks, and that's how the testing was ordered, or the pain was present. It wasn't for exocrine pancreatic insufficiency, or it wasn't for the presence of the diabetes in patients. What diagnostic methods were used? Again, I mean, it's quite possible. I think it's more than one was used so that the total is not 100%. A lot of times, MRCP or ERCP were used to make the diagnosis of chronic pancreatitis and clinical suspicion. Some patients with abdominal ultrasound. EOS was used only in 11%. The first imaging findings of chronic pancreatitis in children was a lot of times is duct-related, either ductal stricture or ductal dilatation. We haven't seen a lot of calcifications or stones in children as the first imaging finding. And there was also a significant number with pancreatic atrophy. When it comes to pain, 85% of children with acute recurrent and chronic pancreatitis reported pain within the last year. If we look at the ARP, most of the pain was episodic in acute recurrent pancreatitis, but there was a subset who was complaining of the chronic pain. And this may as well be the early chronic pancreatitis, minimal change chronic pancreatitis, that it is difficult for us to make the diagnosis, not only in pediatrics, but also in adults. The chronic pancreatitis, the pain most commonly constant in this category, but there were about 20% of the kids who had episodic pain. When it comes to disease burden, what happens to those kids? Do they visit the ER, hospitals, being hospitalized, or how much school do they miss? When we look at the acute recurrent pancreatitis in that group, within the previous month, none of them missed any school. Versus 2 days a month of the schools were missed with kids that got the diagnosis of chronic pancreatitis. And that was significantly, it was significantly different. If you look at the ER visits and hospitalization, this is lifetime. So the ER visits and hospitalization in both categories about 2, hospitalizations about 4. Again, it's more significant, it's more frequent in the CP group, but that could be expected because it accumulates over time. And those kids have average attacks about 3 per year. So I think they learn to stay home and deal with this at home after a certain time. How we treat those patients, looking at, again, acute recurrent pancreatitis and chronic pancreatitis. Acute recurrent pancreatitis patients don't get much treatment. I mean, the medications, about 20%, ERCP and surgery. And most of the time, ERCP and surgery is to relieve a biliary obstruction, or cholecystectomy is the surgery. But the ERCP, the number of ERCPs and surgeries are higher in the kids with the CP category. So in summary, I think we're finding out that the kids get pancreatitis and can get acute recurrent pancreatitis and chronic pancreatitis. And unlike in adults, where you see commonly the association of alcohol and smoking, this is not very common in pediatrics. So we see more genetics and obstructive factors in pediatrics. And a genetic mutation is identified in the majority of children with acute recurrent and chronic pancreatitis. Obstructive factors are the second most common, and 25% of them have pancreas divisum, that have pancreas divisum also have genetic mutations. And we're also finding out that this is significantly affecting those kids. I mean, they miss school, they get hospitalized, and they go to the emergency room. And the pain, I think, significantly impacts their life. It's a significant disease burden. And about 85% of kids with ARP and CP have pain, and pain is more episodic in the acute recurrent group, and it's more chronic and constant in the chronic pancreatitis group. And genetic factors probably play an important role from progression from ARP to CP. So we think that as the INSPIRE Consortium, we have a unique perspective to understand pediatric pancreatitis, the risk factors, the presentation, and the outcome. And it's a genetically enriched population with not a lot of environmental factors present. So it also gives us the opportunity to investigate the role of genetic factors in pancreatitis. So the future directions, where would we like to go from here? We would like to understand our cohort better. I think a comprehensive clinical, epidemiological, and biological characterization of our cohort is what we would like to do. I mean, we would like to expand the genetic workup, and that's largely depending on the funding. And we would like to study the predictors of sequelae. I mean, what are the factors that predispose children from acute recurrent to chronic pancreatitis? Why does it progress? And can we diagnose those kids at an earlier age before things progress further? And what can we do about pain? How can we affect their lives? How can we treat the pain? How can we increase the quality of life? And can we predict the ones that will have pancreatic insufficiency and pancreatogenic diabetes? And can we develop the modeling approaches that will identify those kids at a younger age? And finally, the clinical trials. I mean, can we design clinical trials to treat those patients, and how can we assess the outcome? And this concludes my talk, and this is the current members of the INSPIRE Consortium. I would like to thank everyone for their contribution to the study. And the funding is from NIH and CTSA at the University of Iowa. Thank you for your attention.
Thank you for the very nice presentation. Questions, please.
Very nice data. If I would believe on string theories, and I would believe that there are parallel worlds, 80% chronic pain cannot be. Sorry, we do not observe it in German children, and we have a registry of more than 500 children. And this is a very rare occasion. And so maybe we have different definitions. What is chronic pain for you?
Well, 80%, 84% experienced pain within the last year. So a lot of them were episodic. I think a lot of them are associated with an acute attack. But I think in chronic pancreatitis, right, I mean, 80% of that cohort had, I mean, I think I should say mostly were mild pain. But I think, you know, because we asked the question, we got the answer, and that's more in the chronic pancreatitis
Do
category.
they have type B pain? This is type B pain.
Type B pain, how do you describe?
Constant pain, or it's a recurrent attacks, 10 attacks or 10 pain attacks a year, or just have pain every year. What does it mean, chronic pain? Every day.
Right, I mean, if it's constant pain, it is daily pain. But the constant daily pain was a smaller percentage compared to the episodic pain, and more common in the chronic. I mean, those are the things, those are the questionnaires we collected from the patient. I mean, this is strictly from the patient information that we collected.
Okay, what's your experience?
Maybe for me it's easier because I've got a little bigger group, but from the single center. That's why I observe these patients through the last 15 years. And probably in Europe we've got less pain patients because it's very rare to have a really chronic pain in the patient with chronic pancreatitis. They have a pain, of course, from time to time during the exacerbations, of course, but it's not a chronic pain. The first one, and the question, how do you recognize sphincter of Oddi dysfunction? Because I can perform a sphincter of Oddi manometry, but it's possible to perform it in the children during the ARCP. I think it's not true with the sphincter.
Well, we're looking into this. I think the sphincter of Oddi dysfunction, I mean, some, you know, measured, some did the manometry, and some it was the clinical.
You perform sphincter of Oddi manometry in the children?
Well, I mean, we have up to 19. So, I mean, we have a group 0 to 19. So it was done in some of our patients, but it is a very small number of patients.
But it was recognized by manometry?
Some were. I mean, there
there
are
was 10
SOD
patients
type
with
3
sphincter of Oddi
definitions
dysfunction.
for, you know, but we're working, I mean, I mentioned for the toxic metabolic, but the same thing for SOD and the same thing for acute autoimmune pancreatitis. I mean, we're trying to come up with the definitions that are specific to pediatric SOD. I think it's going to be, I mean, it's going to be quite rare. It's already rare, but I think it's going to be quite rare.
I'm sure that we lose these patients, but it's very difficult to recognize it.
Absolutely agree. Dr. Whitcomb.
Just to make a comment about SOD. So we've looked at SOD and the NAPS2, and there are some centers in which it is one of the major diagnoses. Many other centers have never seen a case, and so we're trying to sort that out. This is what's happening when we first do questionnaires. You get a bunch of answers, and then you start looking at it, and then you can start getting into mechanisms. So I think a lot of it has to do with the person enrolling and their prior opinions.
Because sometimes it's recognized during the RCP, but it's not a good examination to recognize.
Yeah, I mean, this is one, right. I mean, this is the reason we're going, you know, every 2 years. I mean, we look at our data and we look what is, you know, our needs, what is our population, what are the answers, and we make changes. I think there will be changes in the questions about SOD. I mean, we will ask for some very solid criteria before the PIs checks for SOD.
I noticed you have very high PRSS1 frequency. So do you think there may be an enrollment bias? People tend to send their sickest patients to the database.
You know, I think this is what we see, and it's not only one center. I think, you know, PRSS1, you know, it's across the 14 centers that we had is quite common. But I mean, like in Cincinnati, we have they have a very small population of PRSS1 and a lot of CFTR mutations. So I think, you know, those are the kids that get chronic pancreatitis that get more pain and more complications.
I saw the presentation in the journalism in Israel, and I talked with some professor from the state and said in the, I forget the name of the state, but in the one of the state is a region with a lot of the hereditary pancreatitis patients. That's why most of these patients are from the one region. I forget what the state, but this professor told me.
Well, I think we all have PRSS1.
I can write you what was the
Yeah.
because I have got
But you showed like above 40%, which it doesn't seem realistic that 40%.
We have less in the ARP category than we have in the CP category.
I think maybe you can call it really like a testing bias, like you said, because it's the providers are the ones who test. So if a provider only wants to test for that gene and it's positive, then that's one way. The hope is that Inspire, you know, once we want to do like more thorough gene testing, the way we don't have a homogeneous test that we order for everybody and then say what is the frequency of this mutation in this patient population. Maybe the most, as Aliye said, is what we try to do in our registry where we test everybody, whole gene sequencing for the 4 most common genes, but there are new genes coming every day, right?
So this is another issue. So who you consider having genetic susceptibility? Because it turns out with the new genes that not everyone has a genetic risk factor. We tested my lab, you know, all my lab members have genetic risk factors for chronic pancreatitis. I mean, obvious we don't consider each other, you know, genetically susceptible, but so now we need a new definition, you know, because it used to be PRSS1 and then SPINK1, and now with the clouding and some of the very frequent CTRC variations, it's 80–90% of the population. And CFTR is a complete mess, you know.
Yeah, what do you tell those patients? You have one CFTR mutation or one SPINK, CTRC, is that a genetic predisposition? We know they're modifiers, but that's the...
I think for PRSS1, I mean, the test is done if like a family member, you know, with PRSS1 mutation comes in, and only that gene mutation, I mean, it's usually done because, I mean, we do not pay for this testing as Inspire. I mean, Inspire doesn't have the funding to pay for all the genetic testing, at least for the time being. So we go with what the clinicians have ordered, and if only PRSS1 is ordered on the patient who comes in with a family member who has a PRSS1 mutation, well, this is the only thing you have. But, I mean, this will be extended. I mean, this is just our first look at our, you know, database and, you know, seeing, well, we're not seeing alcohol, we're not seeing smoking, we're seeing obstructive factors, and we're seeing, you know, already a, you know, genetically very enriched population.